to remove the wax on the day, and they requested the patient to use some olive oil drops and attend the next training course, which was scheduled for the end of March. Obviously lockdown occurred and the patient wasn't able to attend that training course. One thing led to another. The patient just kind of coped with his impaction, but it got to a point last week where he felt he needed to get it treated and removed. You can see there the wax is quite lodged, it's really deep in the ear, so it's quite medial. The wax is also quite dark in colour, so the wax is oxidised, which implies that it's been there for a long time. When the wax is lodged, we just have to first of all loosen this wax from the canal wall. As we enter the ear canal, we have two bends, the first bend and the second bend, and then we have a narrowing of the ear canal called the isthmus, which is about 5 millimeters away from the eardrum. And after that narrowing, the ear canal protrudes outwards again, and this wax is lodged beyond that narrowing. So the secret here is to delicately loosen the wax from that narrowing and slowly bring it forwards. And what you can see here, I'm just at the roof of the ear canal, just trying to bring this wax forwards and downwards, just trying to bring it slowly forwards, almost wriggle it out of that narrowing. And you can probably see that narrowing on the right hand side. You can see the bony part of the ear canal is protruding inwards slightly on the right hand side. The wax is slightly matted as well. I gave some advice to the patient afterwards when trimming his ear hairs, just to put a piece of cotton wool at the entrance, so when he does trim his ear hairs, they don't fly loose into the ear, because that can lodge against the wax, making it quite difficult to remove. Again, I'm just at the roof of the ear canal, the top of this large piece of earwax, just trying to bring it forward. It's a bit sticky here, so I think on a couple of occasions I've had to come out and unblock the suction probe. If the suction probe gets blocked, we use a cleaning rod, so we thread it through the suction probe to push through any debris that's got stuck. And I've just gone back to that on the right hand side of the ear canal, where you can see the ear canal slightly narrowed, it's coming inwards on the right hand side. Again at the roof of the ear canal, just trying to bring this down, so below the narrowing of the ear canal. It was really impacted. You can imagine it's been there for the best part of 6 months now. The patient was almost completely deaf in this ear, and this was the worst ear out of the two. And you can see the entrance of the ear canal is quite clear, so there wasn't much wax there. The patient he doesn't report using Q-tips or cotton swabs or cotton buds, but he does wear earbuds, and earbuds can unfortunately inadvertently push and force wax further in the ear. So I've just gone to the posterior canal wall, which is the back end of the canal, and I'm just able to get a good suction grip here, and I'm just going to be rotating this wax now and wriggling it forwards. You see the wax here is a bit drier, whereas the wax where I was concentrating before was a bit softer, and it was causing the suction probe to get blocked. So I've got a slight better grip here, and I'm just lifting the earwax upwards. You can see the position of the wax now. I'm trying to wriggle it up and away from the eardrum, and I've brought it forwards about 1 centimetre, and I've got a really good suction grip here. And we're now near the entrance. And we know you're near the entrance because you can see the cilia. So the cilia are the hairs. They're normally found in the outer third of the ear canal. Typically wax is also secreted in the outer third of the ear canal. That's the cartilage portion, and the skin that coats the outer third of the ear canal contains the ceremunous glands and sebaceous glands, and they're the glands that are responsible for the secretion of wax. So quite often when you've got people with wax very deep in the ear, you kind of know they've either used a cotton bud or an earbud, or they wear a hearing aid, because wax typically shouldn't be found that deep in the ear. So this big chunk of wax, it's just at the entrance, so I'm just trying to wriggle it through, and there we are, I've got a big segment there. The wax itself, that big segment was so big it just wouldn't come out in one go through the entrance. So most entrances of the ear canal are narrow than the rest of the ear canal itself, so you get a narrowing as you enter the entrance, and the ear canal protrudes outwards. Then you've got two bends, and then it narrows, and then it widens again. So just gives you an idea of the ear anatomy. I'm just going to let you watch me wriggle this big piece of wax out the canal. And to do that, I'm having to use the endoscope to stretch the entrance open. So I've just inserted the tip of the endoscope just past the entrance and pushing the cartilage to the left to widen the ear canal entrance so I can remove that piece of wax. I thought that would be all of it, but you can see there's another big piece of wax here, really lodged against the eardrum. This wax is a bit softer, so the oil that the patient had been using had penetrated through the outer layer, and it was almost, it settled in behind the wax, which made it easy when removing it off the eardrum, so you have some natural lubrication there. And you can see at the base there, as I'm moving this plug, you can see a thin layer of dead skin that was kind of just on the surface of the base of the ear canal. So in essence, that's job done, but there's just a bit of wax there that I felt comfortable removing. The patient was very still, so the piece of wax is in the superior anterior quadrant, which means the northeast, if you're looking at a compass region of the eardrum. Some remaining there, so just attached to fine end gauze, just getting into the anterior recess. So that's a little kind of a recess, kind of a trench, a vertical trench to the right hand side of the eardrum. Just mopping up near the entrance. There is some debris at the base of the cartilage portion of the ear canal, and that's quite easy to remove, and just hovering over. And if we do make contact with the canal wall here, it's not very uncomfortable for the patient because the cartilage portion is quite malleable. There's some fatty tissue underneath. However, you'll see a bit deeper in the ear on the posterior canal wall, there is some surface dead skin. It's not clinically relevant, and there's some staining on the eardrum there, just at the base. So this wax was stuck to the eardrum, so inevitably when you extract that wax, you're going to get a few remnants. It's not significant. As a clinical ear care specialist, I read some of the comments on YouTube, and you've left a bit here, you left a bit there. It's not because I'm lazy or inefficient, and it's just, as a clinician, you just do what's necessary. We're not here to mop up every single little last speck of wax from the ear canal. A bit of earwax is actually healthy. That's why we secrete it in the first place. Earwax is slightly acidic, so that acidity inhibits certain bacterial growth in the ear. The acidity can also help repel insects and bugs from entering the ear. Earwax is slightly greasy, so that greasiness helps lubricate the skin that coats and lines the ear canal, preventing it from drying and cracking. And in most cases, earwax naturally migrates, and as it's sticky, any foreign particles, so pollen, debris, dust, as it enters the ear, it sticks to the wax, and as this wax migrates, it expels with it all these foreign particles and bodies. So a bit of wax is actually good for you. So if ever you see a video and there's some wax remaining on the canal wall, or even a little speck of wax in the eardrum, it's fine. That's not a problem whatsoever. I've got more wax in my ear compared to the patient's right ear, the procedure that I've just done. So anyway, so we're just doing the left ear. This ear was a bit easier. It was the better out of the two. The patient didn't notice as much as a blockage, but you can see there is a hell of a lot of wax here. This ear also is a bit narrower, and his second bend was a bit more pronounced compared to the right ear. So there's a bit more of a twistier ear. But similarly, what I'm trying to do is just get a suction grip. I'm just trying to wriggle this out. So again, this piece of wax is lodged in the natural narrowing of our ear canals, very deep in the ear. It's a bit sticky here, so as I'm extracting the wax, you can see the wax stretching almost a bit. And we're just using almost little gentle brush strokes to wriggle and loosen this wax, bringing it forward. So I'm going round in circles, and that helps detach the wax from the canal wall. You can see just at the bottom there a bit of dead skin as well, keratin, that's just attached to the wax as I'm removing it. Similarly to the right ear, the wax is really dark in colour, so we know it's been there for a while, it's oxidised. You can see the wax and a bit of keratin at the top of the wax there as well, so that's come off the canal wall. And I think this is the last piece, and it's quite the bigger piece. And we're just entering the ear canal again. You can see on this occasion, because it wasn't lodged right and compressed against the eardrum, there was no staining, so the eardrum's nice and healthy, no remnants. Again, just a bit of soft wax at the entrance, just mopping that up with the suction probe. And the patient was extremely happy. Could hear again. He had no excuse for hearing his partner, he said. and in a minute you'll get a final view of the eardrum again. There we are, and you can just see the incus as well there, the second of the middle ear bones through the eardrum. That's translucent. That's all the contents of both ears. You can see there's quite a lot of wax, quite dark. I hope you enjoyed that video, guys. I hope everyone's keeping well and safe. If you're watching on YouTube for the first time, please do subscribe and select the bell icon